Good morning, everyone. Thanks for joining us for another episode of Surgery Live. Very excited for today's episode. And with that, let's get right into our presentation. I'll hand it over to Dr. Stephanie Valente to introduce Dr. Downes and our topic of breast angiosarcoma. Thanks for being here.
Thanks, Dr. Rosen. Thanks for having us this morning. I'm Dr. Stephanie Valente. I am a breast surgeon here at the Cleveland Clinic main campus. Today with me presenting our case is Dr. Nicki Downes. She is the breast surgical oncology fellow at Akron General Cleveland Clinic. And so I'll let her describe our case presentation today, and discussion is regarding angiosarcoma of the breast.
Yes, thank you very much, Dr. Valente. Thank you so much for having us here. I'm honored to be able to talk about this with your group. So we're just going to start. We don't have any disclosures with our case presentation. So we had a female about a couple months ago who came into our medical oncology clinic with complaints of right upper extremity pain that kind of extended down into her lower breast, some swelling and bruising, and then some thickening centrally in her breast as well. This did abruptly begin about 2 days after she had a flu shot. She had no other systemic signs or symptoms of infections. She had tried some NSAIDs with some relief, but really nothing really helped completely. Nothing made it worse, and there were no other associated findings. She does have a significant history of being treated for stage 1A invasive ductal carcinoma in 2016 with breast conservation therapy. She underwent about 16 fractions of radiation for a total of 42 gray. She attempted endocrine therapy but was unable to tolerate it. She is healthy though, just has some rheumatoid arthritis, didn't take any steroids or immunosuppressants for this, does have a family history of breast cancer, and herself is not a substance abuser. So here we can see the pictures that were taken on examination for her. The area of concern is around the nipple areolar complex, and as we saw each other for the next couple weeks, that was the area that became more painful. But there was some redness and bruising. It kind of extends inferiorly and medially, but then you can see around the periphery there's these reddish brown purple plaques. So it's kind of extensively involving this lady's breast. On exam, she had complete resolution of her right arm pain and tenderness and didn't have any signs of lymphedema at all. So we'll go into our first poll question here.
So this is for the audience. This lady comes to your clinic, history of breast cancer in 2016, got a flu shot in that arm. She had a sentinel lymph node biopsy only, and you said no fevers.
Nope.
What would your next step in management of this patient be? So we've got a poll question coming up. Would you A, start a course of antibiotics, B, do a skin punch biopsy, C, diagnostic imaging, or D, a course of anti-inflammatory medications?
And this is actually a good question because I feel like these questions are the ones that you get in your boards. It's kind of what's the next best step. Now, a lot of these things can be done and eventually they will be done, but I think there's one right answer or best right answer.
So we can talk about it a little bit. If you were going to start antibiotics, what antibiotics would you focus on for somebody with a breast infection?
Especially after the setting of an injection. I mean, we were just thinking just skin gram positives. We weren't really thinking there was any reason to cover for gram negatives. She's not a smoker, didn't have any nipple piercings or anything like that.
Was she compliant with her imaging follow-up, where she had an imaging recently, like the last year?
She had, yes. She was definitely compliant.
All right. Are we able to do the poll? All right. We've got 15 seconds left on the poll. And just kind of talking about diagnostic imaging, what would you be ordering for somebody? What are you thinking?
Mammogram and ultrasound would be our first jump to for this patient.
Okay. And then anti-inflammatory, you're just thinking like NSAIDs?
Yeah, just
give
in
it some
case.
time.
Yeah, in case this wasn't something ominous like AS and it was something, just like an inflammatory reaction.
Okay. So looking at the poll questions, 20% of the audience recommended starting with a skin punch biopsy, and 9% said proceed with diagnostic imaging. So if you want to go on with what you guys did in this
we
case.
actually proceeded with diagnostic imaging. If we could have the slides back up here. There we go. So she underwent a diagnostic mammogram, and here you can see it's Really the only major finding is some thickening of the skin around the nipple areolar complex there. You can see post-surgical changes, but there's no underlying mass, no gross asymmetry that's kind of standing out at you. And so we then went ahead and got a diagnostic ultrasound.
Yeah, her surgical site looked pretty good there, so no signs of recurrence
Yeah.
in the breast.
Yes, ma'am. And then you can see on this imaging circled in red on the right, they did scan from about 2 to 7 o'clock and really, again, didn't find anything impressive except for that dermal thickening there. Of note, there is some vascularity, but it's not like hypervascular that you would think you would typically see. And so they read this as a BI-RADS 4, and like I alluded to in the question, while we were waiting for our diagnostic imaging, we did go ahead and start her on a course of antibiotics, and we gave her Keflex. Just again, concern.
And that's
for any
reasonable.
infection.
Yeah, I mean, she did get a flu shot. That can happen.
Yeah.
Okay.
There wasn't really any resolution though, so.
With the antibiotics.
Yeah.
Okay.
And so given the concern for the thickened skin and our differential diagnosis, we went ahead and proceeded with the punch biopsy. And here on image on the left of the screen, you can see the superficial punch biopsy. And the reason I included this is just, to kind of speak to the nature of angiosarcoma and also to speak to the nature of obtaining a good surgical punch biopsy. This on the left really isn't really impressive. There's some epidermal sloughing there. And overall, we just kind of call this chronic inflammation. But when you look deeper on slide right into the deep dermis is where you start to see things that trigger you to say, something's not right here. And the background behind all that pink, there's that light blue popping through kind of in this channeling type fashion. And they call that vascular tuffing. And it's lined with endothelial cells. So this isn't entirely normal, and it kind of made us think, are we dealing with an atypical vascular lesion here? Are we dealing with angiosarcoma? Some other things as well. And just a note on atypical vascular lesions, there's a train of thought out there that these are kind of on a spectrum. They in themselves are benign, but they are post-radiation consequences. They arise from similar underlying reasons from that lymphatic obstruction after radiation, but they usually present a couple years earlier, like 3 to 4 years out. They look very similar, but I would say overall the ones that I've seen are smaller on scale and presentation. The problem is the morphologic overlap. So when you're looking at these images under the microscope, and if you look at the image that we've included here on the right, in comparison to that previous superficial image, you see these kind of lymphovascular lakes that are pretty superficial in the dermis. That's more classic for atypical vascular lesions than for AS. AS is going to be a lot more deeper, where you start to see that vascular tuffing and those lymphovascular lakes. But what really distinguishes the two is the immunostains that we got. And
so when you see somebody in clinic, how do you differentiate between them?
So I think most people would recommend excising. I think it's a safe bet. Like I said in the beginning, this can be on a spectrum, and
Or performing a skin punch biopsy?
Yeah.
Okay.
Yeah. Tissue analysis definitely is the best. And even if your punch, you still have a concern, then I would go ahead and move to excision just to make you feel better about yourself, make sure you're not missing anything. But for these stains, we usually look at Ki67 and MYC expression. And for avascular lesions, these guys are low or absent. And it's the opposite for angiosarcoma.
So that leads us to our next poll question, if you guys were paying attention. How do you distinguish, or how do your pathologists distinguish between atypical vascular lesion and an angiosarcoma? So if you guys want to take the poll, are you going to do it through a physical exam? You're going to have a negative c-MYC amplification, CD34 positivity, or morphologically?
And so a couple of these are more academic than really anything. But when you're looking at those first images that we included of the deep dermal, a couple other stains would probably be undertaken before we just skipped to the ones that I talked about, and kind of just to lead us down the pathway that we're actually dealing with a vascular anomaly versus a smooth muscle anomaly or some other surrounding tissue.
Right. All right, do you want to move on just in the sake of time, and then we'll see how the audience answers after you give your answer.
Okay, so the answer is B, so MYC amplification. This is going to be quite classically high with angiosarcoma, as well as you'll often see a high Ki-67. It's not always, it can be low in the well-differentiated, but you more than likely will see that. And so if we move to our next slide, where we talk about this, on the image on the left there, that is actually the CD34 imaging, which is the vascular immunostain. We then moved on to the one on the right, which is the MYC amplification. And this is positive. It's those little brown spots. And that's actually very superficial in that punch biopsy, which is interesting because we really didn't see any morphologic changes. So keep that in the back of your mind. It also speaks to the nature of angiosarcoma.
So in her case, you guys did a skin punch biopsy and got the diagnosis of angiosarcoma. So what do you do next?
So then we moved on to our metastatic workup, and we used our Cleveland Clinic pathway here to direct what we were going to look at. So we underwent the CT chest, an MRI of the breast, and then we had already gotten our breast diagnostic ultrasound and mammogram. We also obtained some baseline labs.
And so this, the management of angiosarcoma, just for the physicians that are in the Cleveland Clinic, is part of our care path under the sarcoma pathways on the TOSIC intranet. So this is where we're pulling this from.
And as you can see, the breast MRI, it's a little bit more impressive than what we saw on the diagnostic mammogram, but there's that nipple areolar skin thickening. There's that enhancement that you see there that actually on screen right is extending pretty posterior from the nipple areolar complex. And what you can appreciate here is it extends quite medially, almost crossing midline. And the enhancement is actually pretty lateral as well.
So that makes it a little difficult when you're planning your surgical excision, but it's helpful knowing that at least on imaging, all that skin needs to be included.
Yes, absolutely. And just for edification, I mean, it's interesting to see that this was her her pre-simulation images that kind of looks at the trajectory and where she's going to get her her dose for her radiation that she got in 2016, and it correlates quite well with the MRI areas of enhancement. And so for treatment options of angiosarcoma, like most cancers, we have three modalities. We have surgery, which traditionally is the mainstay approach, and then we have adjuvant or neoadjuvant chemoradiation. Now, I think...
Yeah, so we do have, I think, an expert in the audience, Dr. Rogula. Do you have an expert who wants to chime in about management of angiosarcoma?
Thanks for opportunity. I'm not a breast surgeon at all, as you know. I'm bariatric surgeon, but I have my colleague Matt. He's one of the co-directors of our breast unit, which is organized pretty much like in US. Matt, go ahead.
Definitely, we do not deal with angiosarcoma that often. It is very rare, and that's why there's the problem with treatment and the pathways of treatment for those patients. We have a center of sarcoma treatment back in Warsaw, and we often consult with them concerning treatment of our patients. We recently had one of our own patients that was one of a kind. It was a bilateral angiosarcoma of the breast, and we will definitely publish after 6 months of observation after treatment. That was a different case than what you're presenting here. She was much advanced. The lesions were 4.5 and 5 centimeters in diameter in MRI. So we went for neoadjuvant treatment, and after that surgical treatment. And now we are waiting for her first 3-month checkup, and we will definitely have a close look at CT scans, hoping for the best. So no pathways here.
What did you give her neoadjuvantly?
Sorry?
What was the neoadjuvant treatment?
We had a little problem with, we had 2 opinions of 2 expert oncologists in Poland dealing with sarcomas. we went for standard AC treatment. She got 4 doses with excellent response in physical and in magnetic resonance. But eventually, in histopathological examination, it turned that it wasn't that good. The lesions shrank only around 20%, and well, the only difference we could see after that initial chemotherapy was decrease in Ki-67.
Yeah, I think these larger lesions are a little bit more difficult to handle because traditional surgery is not going to get it all. And so I think kind of looking outside the box and the difficulty with angiosarcoma is that you just don't see a lot of these. So, you know, publishing case reports like yours with the success of different, you know, modalities of therapy, which comes first, second, and third, are definitely necessary. So we look forward to seeing your publication on your success with this patient.
Were you able to get negative margins or no?
Yes, definitely good surgical margins. So it's an R0 operation. Yes, but what we are afraid of is the metastasis, and we're hoping she will be metastasis free. But with that kind of with that size of primary tumor, it's only actually hoping for the best.
Right. And that's actually a great segue into the next part of our presentation, is management of angiosarcoma. Dr. Downes?
Yeah, if we could put our slides back up.
So leading into that, if you do have an angiosarcoma and you're thinking about surgery first, what are we doing the poll question? Okay. What are the margins of resection? Are you looking for no ink on tumor, a 2 centimeter margin, a 3 centimeter margin, or something greater than 5 centimeters?
So go ahead and put your poll questions in for this, your answers in for this. But there's, you know, like you guys were alluding to, it's difficult for us to do any prospective studies on this because it's so rare. And so I think collectively the literature is leaning towards at least your minimal margin being 3 centimeters, if you can get it, which I think is the biggest issue with the treatment of this, is if you can get the margins. Yeah, so just a little bit about angiosarcoma. I mean, we know that it's a rare aggressive malignancy of endothelial cells, and there's a lot of things that go into whether it's a little bit more aggressive than the next angiosarcoma you see. And when you see disease that's limited to the superficial skin, that's usually associated with a better prognosis than those tumors that are deeper and larger in the breast. It is interesting, though, that of 76% of the patients, 67% of the patients who did have a diagnosis of radiation-associated breast sarcoma also noted that they had a longstanding history of edema of the breast as well. And when we're looking historically at these patients, they usually received anywhere from 25 to 80 gray during their treatments. And there's also, you know, Murray et al. Published a paper, and it's mostly on non-breast angiosarcomas, but what they saw is that there was a shorter latency period found with a higher dose of radiation that people were receiving in the development. So, you know, that's something to keep in mind, and I think that our radiologists have tried really hard to decrease the doses of radiation needed for breast conservation therapy. And so presentation, as you can see in the pictures over here, it's a blue-red plaque. It can be, it looks like a hematoma sometimes, looks like ecchymosis. There's often skin thickening associated with it. It can look like cellulitis. And that would explain why we kind of went down that pathway of giving her a dose of antibiotics. For radiation-associated angiosarcoma, it presents about 5 to 10 years after the exposure, and then for lymphedema related, it can be later, 10 to 20 and sometimes 40 years, but it can pop up about 6 months after surgery or after radiation is complete, so you have to keep it on the back of your mind. And then diagnostic imaging, just for the sake of time, we went over the mammogram. They often are non-specific. And then the ultrasound, you typically are going to see that hypervascularity there in the dermis on the right upper hand picture. And then the MRI is pretty, spot on. You see all that enhancement there. So pathophysiology, there's a couple things listed here, but essentially they all revolve around damage to the DNA and genomic instability that causes mutations. There's several listed. I haven't seen anything yet looking at using it as a target for any treatments or any research yet. So to be followed. So grading of angiosarcoma in the NCCN guidelines, they have the FNCLCC, which is the French Federation grading scale here, and it looks at three major parameters. It looks at tumor differentiation, mitotic count, and tumor necrosis. And collectively, it gives you those grades. And the good thing about this is that not only do you get a grade of what type of, angiosarcoma you're dealing with, it provides you with prognostic information about rates of metastasis and tumor mortality related to those patients. So there's just our NCCN guidelines, just like other cancers, it's a TMN staging, and then they have the grading as well in there. Here at Cleveland Clinic, we have this radiation-associated sarcoma pathway, that begins on the far left with diagnostic and staging, middle is treatment, and then surveillance on the right. When we look kind of in the middle there about the treatment pathway, here at Cleveland Clinic, we tend to look at the patient and say, are they resectable? And then also we ask a question is, are they a candidate for neoadjuvant chemoradiation? And then yes or no. Both patients, though, we want to go ahead and consult medical and radiation oncology as well as palliative medicine, discuss the patient in the multi-discipline tumor boards that we have here, and then decide if they are a candidate. If they are, then we usually like to proceed with preoperative chemotherapy and radiation. And if they're not, then we can go ahead and proceed with the standard, the older traditional treatment, which is surgery up front, followed by discussion of if they can undergo adjuvant chemo or radiation.
And I think this is really important. So I think when we see patients get the diagnosis of angiosarcoma, we bring the patients back, and we definitely have a multidisciplinary clinic where they see medical oncology, radiation oncology, plastic surgery, to kind of really get a handle on what's the extent of disease, what's the baseline functional status of this patient, and can they tolerate the treatments that are going to be recommended.
Yeah, absolutely. And so we also have had some success here with implementing in the few patients that we've treated, since it's quite rare, this alternative pathway that we embed kind of in our pathway sometimes, and it's the Mayo Clinic's pathway. And basically what they're looking at is if the patient is of favorable risk. And the way they define that is, can the patient tolerate a complete surgery with resections and they don't need a flap recreation?
Yeah. And so I can talk to this a little bit because this is one of my patients. So on the left-hand side, she presented with an angiosarcoma. It was large, and it's just in a difficult area to get flap coverage. So she was otherwise healthy, good baseline. So we did follow this pathway, which is similar with a different neoadjuvant approach. So she underwent Taxol, weekly Taxol, for 8 weeks. She was restaged, staging was clear, and then she went for radiation. She got 25 fractions of radiation, and then she healed up for about 3 to 4 weeks, and then we took her for surgical excision. At the time of surgery, there was actually no angiosarcoma left in her. She's out 2.5 years, and knock on wood, no signs of local or systemic recurrence. So we've been following this pathway, and it's difficult after chemo and radiation, getting these patients to surgery, healing their wounds. But once we got her there, she actually healed up great, and we did need a flap coverage for this patient.
So like we've kind of alluded to, there's the traditional pathway of treating patients, and that's usually surgery up front. And I mean, no matter what pathway we go, whether it's neoadjuvant or adjuvant chemoradiation, surgery is the only option that represents, or typically is the only option that represents a cure. And really it's the focus on those negative margins. That's the most important contributing factor. I mean, the majority of these are multifactorial, And just as you can see in the pathology slides that we looked at, it's difficult. And so we ideally want negative margins, and 3 is a minimum, 5 would be phenomenal.
And this picture here for the audience shows a great reason on why we need such wide margins. Margin status doesn't, obviously if you get a clear margin, a larger clear margin doesn't make the patient survive any longer. You just need a clear margin. But the top picture is when I saw the patient in clinic. The bottom picture is 2 weeks later when we were taking her to surgery. So you can see now she's got this large met that crosses midline. So marking out those margins is just going to help ensure that we're getting this multifocal disease. And a lot of times you see this I've seen this yellow hue in the skin of patients, and that's kind of like the impending doom of this is where it's going to go next. We had also talked about, even sometimes you see these patients in clinic, you kind of actually use a ruler and mark out circumferentially the diameter that you plan to resect. And you could even do skin punch biopsy if you have time, a few days before surgery, just to kind of plan out and make sure that that's going to be safe. So this is the lady at the day of surgery. This is the markings for between plastics and surgery and myself of me kind of marking out the margins of plastic surgery, saying, can I have a little bit more skin so we can close her? So this is kind of her markings, and then when the cancer was out, this patient. And she did have clear margins. So once you have that defect, there's 3 ways that you can close this. So one is primary closure, which is preferred. So if you can pull tissue from anywhere and get a primary closure, it's the easiest for these patients to heal up with. Because again, your job is to get them healed up so that if they can tolerate adjuvant treatment, whether it being chemotherapy or radiation, if that's necessary. So primary wound closure is first. The second picture here is where we were able to leave a little bit of skin, and we're just monitoring that this lady was able to have a latissimus flap. And then the last patient is a tram flap, where we did remove all of her skin. When you're doing flap coverage, you want to make sure that usually a free flap is not going to be that well tolerated. It's a long surgery, microsurgery, and these patients might be needing radiation. So definitely bringing over a vascular pedicle. If you can't get full flap coverage, then you can definitely use some type of skin flap, yeah.
And sometimes I've already been radiated twice. So, and so adjuvantly, though, if you do have to proceed down the traditional pathway, there are salvage therapies that have reports of positive outcomes for patients. And so re-radiation, like we talked about with hyperthermia, is good. And then there's also a small number of studies that are showing that hyperfractionation in the neoadjuvant setting, is an option as well. Chemotherapy, again, can be offered either upfront or behind, and it's just based on a case-by-case basis and patient's functional status and margins and tumor grade. Now, the chemotherapy of choice is usually taxane-based therapy. That has been shown to increase local control. And then just in the specific case of a metastatic presentation, there's a small paper out there just with a small amount of patients, but it is showing some impressive survival benefit for these patients when you include propranolol with vinblastine-based chemotherapy. And so outcomes, this is, unfortunately, it's kind of a relentless disease. Local recurrence is common. 50% is definitely small. It could be higher based on the tumor grade at 18 months. Microscopic margins, though, aren't actually associated with increased risk of recurrence, but again, the size and the depth of your original tumor is associated with higher local recurrence. The median distant recurrent-free survival is only 2.4 years, which is pretty ominous. But I think, once we can move down implementing this pathway and seeing if we can follow these patients up retrospectively, that maybe we can get better disease-free survival with,
And I think what we're seeing is a shift in the literature. Surgery removes it, but the biggest issue is metastatic recurrence. And so surgery, obviously identifying this first, not assuming that it's an atypical vascular lesion, because those are a lot more common. So identifying it, because a lot of times it's a bruise, it's a rash, it's something that, a skin punch is easy to do. So identifying it, getting a plan together, not just saying, see, Med-Onc in 3 weeks, seeing patients together because timing is important. And then again, we've kind of shifted a little bit, and some of the other institutions that you mentioned are shifting a little bit to maybe surgery first. Might not be the best long-term control, even though we can remove it, to kind of see that. So I think as we treat more patients, that might become a trend, is to do some neoadjuvant, again, that like the pathway that you showed, radiation, chemo first, followed by surgery, or if it's something small called early, maybe not being so aggressive, doing surgery first, and then holding off on adjuvant therapy as it becomes necessary.
So Mayo actually published a paper in 2015 where they looked at local recurrences, and when the patient underwent the neoadjuvant chemotherapy radiation pathway versus surgery up front, at 11 months, those neoadjuvant patients had an 0% risk of recurrence in comparison to the surgery only patients had an 85% diagnosis of recurrence. So I think that more needs to be done on that. It doesn't really correlate or hasn't been shown yet to correlate with disease-free survival, but I think if we look into this information, a couple more months or years afterward, we may be able to derive that and really cause some good benefit for these patients.
So a great collaborative research group effort for everyone that's out there if we want to pull our angiosarcoma patients, because they had 11. At this point, I'll take any questions from the audience. Great job, Dr. Downes. Okay. We've got a question from Dr. Kolsik. Other than decreasing the irradiated area up front, is there anything during the initial procedure that can be done to decrease chances of angiosarcoma occurrence, like a lymphovenous bypass? I think that's a great question. And I think, if we look at Stewart-Treves angiosarcoma, the upper extremity, that's chronic lymphedema. And, breast, a lot of it is showing lymphedema of the breast. So I think lymphovenous, anything that we can do up front to decrease the chance that these women may get edema of the arm or the breast can definitely decrease the chance that they get this. Again, it's so small, so we don't know if these differences that we're making can do that, but definitely lymphovenous bypass is decreasing the risk of upper extremity lymphedema by upwards of about 10%, which is significant for these patients. I think as we look at the different treatment modalities for radiation that we're offering patients, so these shorter courses, some of the side effects of the shorter courses of radiation that we're seeing in the literature is that these patients are actually developing more breast lymphedema. And so I think as we offer these shorter courses of radiation, we're going to have to follow these patients to see if this lymphedema of the breast is increasing the risk of angiosarcoma, or not. So I think identifying lymphedema of the breast is real. And as you showed, 67% of patients that developed angiosarcoma had a significant history of edema of the breast. Getting these patients to therapy, if you notice that, and then again, just kind of a high index of suspicion in these patients. That's a great question. Anybody else with questions?
Yeah, Dr. Valente, I have a question, and then I think there's one more in the chat that we can get to. But first, we teach our general surgery residents, and I know this because I remember being taught it myself, that, like you mentioned, sarcomas typically metastasize or travel hematogenously. But the mnemonic I remember we always use is that sarcomas race to the lymph nodes. Race is the mnemonic that we teach our residents. They're the ones you have to think about lymph node spread with: R, rhabdomyosarcoma; A, angiosarcoma; C, clear cell sarcoma; and E, epithelioid. Is that just not true? But I mean, you showed some data that says it most likely travels hematogenously. So is that different for radiated induced angiosarcoma, or is that just something wrong we're teaching our residents with regards to angiosarcoma?
No, that's right. And we didn't really talk about it much, so thanks for bringing it up. But if you see clinically positive nodes, then it is recommended in the literature that you do a lymphadenectomy, or at least do maybe a core beforehand to determine if the patient really needs that lymphadenectomy. So no, that is correct, and that is correct for boards, but it's just not often seen. And so even though it's said that it can, it still clinically is not often needed.
And
So you would
especially
look with a ultrasound or MRI. How would you look at that preoperatively?
So our preoperative testing, when we did the mammogram, ultrasound, and MRI, those three together, and I didn't touch base on them, but the axilla is also looked at. And if there's any mention of anything grossly abnormal, then we would have proceeded down that pathway. But in this case, it wasn't.
And I think that brings up a good point. I think, when we talk about other diseases of the breast, such as inflammatory breast cancer, right? So you're doing a modified radical mastectomy. You're removing all the skin, you're removing the lymph nodes, whether or not they look abnormal. It's a little bit different for sarcoma, where we're focusing on, it's mostly disease of the blood vessels of the skin for a secondary angiosarcoma. And so for that case, you're not obligated to do such a radical dissection of the lymph nodes unless they're grossly involved, because that's just not the standard for that. Usually it's localized to the skin. A lot of times, even when you do a mastectomy, because you need that skin closure. But a lot of times when the final pathology on these specimens, it's disease in the skin and not actually in the breast tissue itself. So that's, interesting with that.
Great.
Okay, let's see with.
Yeah, there's a question about, does neoadjuvant or adjuvant treatment for angiosarcoma lead to more risk of angiosarcoma recurrence in the future? Presuming they mean if you're getting more radiation.
Yeah, it seems counterintuitive to give radiation for something that radiation's caused. But that seems to help with local control in the studies that are out there. We talk about reirradiation, using hyperthermia, warming the skin, and so I think there is some value. I don't know if it just kills everything completely, that nothing else can grow back, but I don't think that we have. They're doing even reirradiation for breast cancer now in studies. So if somebody's got a recurrence of just a traditional breast cancer, totally off-label on study, doing reirradiation to see if the breast can tolerate it. But I think in angiosarcoma, we kind of throw the whole kitchen sink at it, because we just, the rates of recurrence and distant metastasis are so high that we want to try what we can. And it does seem like it holds it, but I don't know if anybody's survived it long enough. I'm sure it's out there that it would risk a secondary malignancy because of that.
That's what I was thinking. I haven't read a single paper that talked about it happening, but even with improving their survival with the upfront chemoradiation, I don't know that they're living long enough.
We'll see that second spike. Anything else? Anything else from the group? All right. Well, thank you for listening in to us this morning. And let us know if you guys have any questions offline.
Phenomenal, informative presentation. Really appreciate you guys as always. You guys give such a great Surgery Live presentation on the breast topic, and we really, really appreciate it. That's going to be our last Surgery Live for 2020. Everybody have a safe and happy holiday. We will be back in 2021. Our next session will be Friday, January 8th. Dr. Isan Fatalizado will lead us in a surgical endoscopy topic. And as a reminder, we're switching in 2021. We're going to add the fifth Friday when it happens. So we'll be the second, third, fourth, and fifth Friday from 6:45 to 7:15. We'll see you in 2021, and have a great holiday, everybody. Take care.